for having me. It's really neat seeing you all meeting like this. It's great to see that things continue despite the conditions that we're under at the moment. So I need to share my screen, and I might just ask that we can see that. Here we are. Spoke to me about giving this talk. I thought, oh gosh, yes, there's so much to say and so much to learn. And now I sort of have got to the point where I think, actually, everybody knows so much about COVID-19. So I've gathered together a few things that I think are possibly some of the more interesting ideas. And I've kind of go over a range of different dimensions to this issue so that hopefully there'll be something there for everybody. As you probably know, we have agencies around the world that keep an eye on emerging, re-emerging and resurging diseases. And they come from all over the world. There was a lot of attention early on in the COVID-19 saga about diseases that have come out of China, knowing that we had the swine flu and the bird flu and SARS, which had their origins in China, as well as COVID-19. But of course, there have been many other diseases that have emerged around the world in recent times. And as you can see, well, there are none for New Zealand, but as of yet, but they could come from anywhere at any time. And I think that's a really important point to make, because we really are all in this together, and part of dealing with these is something that requires a global effort. So as of yesterday, this clearly had become a major global issue with well over 1 million cases around the world and nearly 60,000 deaths, with so far at least 207 countries affected. And that's probably an undercount, because many of these countries, as it moves into developing countries especially, will have really poor detection capability and won't know that COVID-19 has reached them until it becomes a serious crisis. The things that we know about COVID-19 at this point that are feeding into the modeling that's being done to help form our response. Firstly, about how transmissible this virus is. So early estimates were really all over the map, around 1.5 to 5.5 people infected per infected individual. So this is a concept known as R0 for epidemiologists. So that's that R0. And what that means is every infected person will infect a number of other people. And currently we think that's somewhere between 2 and 2.4 people. It does depend on context though, so it will vary from one country to another. We also know a really key fact, which is that older people and also males are more vulnerable to COVID-19. The case fatality rate in people who are in their 70s is 3 or 4 times that average case fatality rate that we keep hearing about. And we can see that here, and this is quite a nice visual showing us that, for example, even going from a 50-something-year-old to a 70-something-year-old involves probably 8 times the fatality rate. And it's even higher, it doubles again in the people who are aged over 80. Just coming back to that previous slide, I did mention males. Males are roughly twice as likely to die from COVID-19 than females. This is actually related to the way our immune systems work, being based on genes that are located on the X chromosome. And so females typically will have 2 sets of genes that help to direct their immune system. So in terms of the detection capability of your immune system, recognizing that you're infected with a virus, and also the response capability of your immune system. And so because females have 2 sets of genes to do that, it's more likely that a female will be able to detect and respond effectively to the virus than a male. And we see this in a few other communicable diseases as well. We also know that viral spread and mortality will be heavily influenced by demographics, population mobility, culture, population density, our health system, and a whole lot of other factors, including individual and government behaviors. And what that really means is that we have no two cases around the country in terms of countries or localities that are alike. And it also means that while we can borrow some of the best ideas from abroad in terms of how we respond, we also have to think about our unique situation and tailor our response to the situation that we face here in New Zealand. There's a lot of things that we still don't know about COVID-19. So you will have heard in the media a lot of attention on the mild and asymptomatic. We don't know a lot about mild and asymptomatic cases. For example, in New Zealand, I've noted that so far we have more infections in women than in men. That's quite unusual, and that might actually be an indicator that we're doing a good number of tests given our level of infection. Overseas, there have been countries that have reported more infections in men than in women. So although men are more susceptible to the complications of COVID-19, there's no reason that men should be more susceptible to being infected. And so possibly what we're seeing overseas is that women developing mild and asymptomatic cases, therefore not being confirmed as infected with COVID-19. But those figures vary wildly. Same with the incubation period, it's very unclear, and again possible that it varies by individual, and that's a really key factor in terms of how we plan our response and also how we know whether our response is working or not. Contagiousness of those asymptomatic individuals is obviously very closely related to those previous points. In terms of recovery, when we start thinking long-term about the response and how we manage our ability to respond to this new disease as we move forward, we don't really know yet whether people who recover from COVID-19 have any kind of immunity to it, and whether that's a short-term immunity or a long-term immunity. And that's really important, because if this does become a disease that continues to roll around the world, possibly even becomes something similar to our seasonal influenza, the level of immunity that our population has from previous exposure will influence how we need to respond to this repeatedly. Seasonal effects, again, huge unknown factor. Whether the Northern Hemisphere will benefit from summer coming around and possibly reduce transmission, that's something to watch. We're of course going into winter, and with most communicable diseases, that actually exacerbates the problem. The extent of genetic involvement, again, as I talked about males and females, because we know that there is a genetic basis to our immune systems and how we respond, then it's possible that we will see effects on families that actually mean that some of the worst impacts of COVID-19 can be quite concentrated in some families. Cause of death and how deaths are being coded is a real issue at the moment in the data and how we understand the data. It's always really difficult in the short term within the health system to assign a cause of death. That's often something that takes weeks or months to identify. Similarly, how we code a death, which has to be done in the short term at the moment, some hospitals may be coding all deaths where there has been a COVID-19 infection as a COVID-19 death, or all deaths that occur in a hospital that is overrun with COVID-19 cases as a COVID-19 death. And those may not necessarily be deaths that are due to COVID infection at all. This is just a graphic showing a little bit of that R0 factor that I talked about before and comparing to some other diseases. The one I guess that I would point out most is measles, that you see up there on your top right. Measles has a much higher R0, meaning that one infected individual is going to infect 11 to 18 other infected individuals. And of course, we had a measles outbreak in New Zealand, 2018, 2019. And this is very fresh in the memories of people who work in the public health space. It's also very fresh in the government's memory. And one of the key consequences of the measles outbreak that we had in New Zealand was a measles outbreak in Samoa. And that measles outbreak in Samoa killed 50-odd children, as well as a few dozen adults. And we recognize that in New Zealand, this was largely something that we could have prevented in ensuring higher immunization rates in our domestic Samoan population who were traveling back and forth between New Zealand and the islands. And so that failure, I think, is really motivating a lot of our response on COVID-19. So you'll have all seen some version of the epidemic disease curve and the almost meme graphic that we've all seen about flattening the curve. So the really key thing about this is there's a timing issue. The idea behind flattening the curve is obviously about keeping the peak number of cases below health system capacity. But what it requires is that we intervene really early on, probably so early that we don't even really know what's happening yet. Health system capacity, of course, is highly variable. This is our hospital beds per 10,000 population. We obviously don't have as many as some countries. Italy, for example, you can see has a few more hospital beds per 10,000 population, but they do, of course, have an older population as well. This is another graphic that identifies that we had, at least at this time, relatively low ICU beds per 100,000 population compared to a lot of countries. History provides some really interesting examples of the notion of flattening the curve. This is one that dates back to the Spanish flu epidemic in 1918 and two American cities. So we had the city of Philadelphia, which allowed a huge parade to go ahead in the streets despite evidence that this flu was taking hold, but they thought the numbers were small and the risk must also be small, so they went ahead with a parade that attracted 200,000 people. And a week later, there were already thousands of dead. Philadelphia responded really quickly to evidence that this virus was circulating in the population, but by the time they shut the city down, it was far too late. And we contrast that with the city of St. Louis, which is not that far away, who responded much earlier. So, and here, much earlier really can mean days rather than weeks. So this is all related to what the CDC calls the pre-pandemic intervals and the pandemic intervals. So we've got those two initial intervals called investigation and recognition. And from our perspective in New Zealand, this is what we were going through while this outbreak of COVID-19 was occurring entirely within China. And the virus was being identified and recognized in people who were infected. And they were at the very, very early stages of identifying how the virus was being transmitted. Was it only occurring in people who, for example, had been within the market that they believed to be the origin of the virus, or was it being transmitted between people who weren't there? The initiation stage is really important. The initiation stage is when we know we have a pandemic, we've established that there is efficient human-to-human transmission, and the virus is present. And this is really the stage where we need to intervene, and I'm happy to say that in New Zealand we have intervened, because if we wait until the acceleration stage, it's generally moving so fast at that point that most countries would not be able to organize an adequate response to bring viral spread under control. So the question around that often is, could we possibly have waited a little bit longer? China and South Korea both did bend that curve. So that epidemic curve, they were able to bend it. You'll have seen some of the graphics around that in various media articles. And is it possible that we could have waited? And this is, I'm just going to flip back. The reason I said the acceleration stage is probably too late for most is that China and South Korea had a few things going for them that allowed them to intervene a little bit later and still be really effective. So in China, for example, the initial outbreak was limited to the Hubei province, and they were able to seal off the province. They had some very minor clusters elsewhere, but Hubei was able to be sealed off. They mobilized workforce and equipment from across China and brought it all within Hubei. So they were able to ramp up their hospital beds, their ICU capacity. Everybody was saying, wow, about the building of hospitals within a couple of weeks. But the really key thing was that they also had the workforce to go with it and the equipment to go with it. And that stuff can't be built within 2 weeks, but it can be moved from elsewhere within the country. South Korea had testing capability. They were ready for that. They remembered the SARS epidemic of 2003. They had been heavily affected by it, and they were ready to ramp up testing capacity and did so immediately upon hearing about this emerging virus in China. We were not ready. Italy and Spain are probably similar examples to what things could look like for a country like New Zealand that was not actually ready to respond during the acceleration phase. They did try to bend the curve during the acceleration phase with measures that are quite similar to our level 4, and their health systems have been overwhelmed. And I take that, you know, their populations are older and they possibly have more intergenerational contacts than what we have in New Zealand, but they were very similar to us in that they didn't have the capability to spring into action at a moment's notice. So a lot of this issue of capability came out in a report that was published actually only just last November, and I'm sure that the organization responsible is patting themselves on the back for their timing. New Zealand came out 30th out of 60 high-income countries for pandemic preparedness. And you can see from the graphic here that actually we scored particularly low in detection capability. And then within the health system category, we scored quite low on infection control practices and on availability of equipment. So some of these issues have obviously come out during the COVID-19 pandemic and have been raised in the media. And so this, for me, is an indication that for New Zealand, it was actually really crucial that this virus hit us quite late. We're lucky that it did, and it's given us some time. Possibly some of our border control measures may have bought us a little bit of extra time so that we could do some work to help lift our capability in some of these areas where we knew we were already quite low. So an example of how we've done that, this is showing the tests per million population in the blue bubbles on your left compared to the size of the population in the pink bubbles on your right. And when the COVID-19 cases were first showing up in New Zealand, we were actually testing, we had testing capacity of up to 700 per day. And so that put us sort of roughly between Japan and the UK, sort of around 120 or so tests per million population. And since then, we've really ramped up our testing capability to well over 3,000 tests per day. So we're now up above Taiwan and just below Italy on this graph. So the graphic here is quite static, and so it's possible that some of those other countries have been moving as well, but I think we've done quite an impressive job of ramping up our testing capability, and this is really crucial for us to be able to design our response and to know that we're responding to the right level at the right time. Testing is really crucial, but detection will tell us how many cases we have. It'll tell us where those cases are. It helps us to identify people who, if they have pre-existing conditions and have tested positive to COVID-19, we can start managing their health a little bit earlier to help prevent some of the severe illness that we've seen. But what it doesn't tell us is where we are on the curve. So a lot of the curves that we're seeing in the media are obviously theoretical contagion curves. They're nice and smooth, but the empirical contagion curve, an example of Chinese one showing there on the right, is often really messy. And that's because testing varies over time. We start off with low testing capability and it ramps up. We change the criteria. And sometimes even the type of test changes and becomes a more reliable test over time. So often it's very difficult in the early stages to know exactly where we are on the curve, and that makes planning a response that much more difficult. This is an example of seasonal flu epidemiology curves from some Canadian studies. And this, I think, just really drives the point that very early on in a pandemic, it's very difficult to know what's going on. It's very difficult to know that we're at the early stages. And it's not until we have more cases that we can actually start to see a pattern and a clear curve emerging. But by then, the outbreak has taken on such a life of its own. And with the level of transmission that we're seeing for COVID-19, things escalate so rapidly that the system is unable to catch up. So I downloaded this graph yesterday showing where New Zealand is at the moment. Yeah.
Sarah, you might want to consider, you know, if you have a quick wrap-up slides or anything like that.
Am I running out of time?
Yep, running out of time as I signal in the chat box. So.
Oh, okay. All right, I won't be long. So what I find encouraging here is if I zoom in, I think we're seeing some early evidence there that the lockdown in New Zealand is starting to have an effect that's encouraging, and this will be what we've seen the Prime Minister talking about as well. We started off escalating quite rapidly, but now we're moving in a line that's probably more parallel to, what are we seeing, Taiwan, Singapore, Japan, which is where we'd like to be. Key issue is, even if the lockdown is successful, we're not out of the woods. We're expecting to see a resurgence of this disease in the future, and so we need to really be thinking long-term about how we manage that. We also need to think about drawing from those best examples overseas in terms of our response, but we also need to tailor it to our unique context. Isolating the most vulnerable is really difficult here because it's not just our older people, it's also our Māori and Pacific populations. And that's because comorbidities have really been driving a lot of those high mortality rates that we're seeing in older people. It's the presence of cardiovascular disease, diabetes, respiratory conditions, etc., that are doing that. But those diseases also exist in Māori and Pacific at a much younger age, people in their 40s and 50s who are much more difficult to isolate. In terms of economic impact, no, we don't want to hit a flea with a hammer, but we're probably not talking about a flea. The economic impact that comes from a global pandemic like this isn't just the direct costs from sickness and mortality, it comes from the aversion behavior that we see. And a lot of that aversion behavior isn't government mandated, it's just individual response to disease. And particularly, you know, in this day and age where people have access to global media, a lot of the aversion behavior that we see is in response to progression of the pandemic that we see overseas. In terms of how it plays out, it will play out through supply side disruptions that generate the kind of uncertainty and panic that drives household and business behavior. And that leads to a drop in consumption. And that, of course, then leads to reduced cash flow for businesses and triggers cycles of layoffs. And so for those who like economics graphs, demand and supply curves, we end up seeing multiple shifts, starting with supply, and then it's a turn-taking exercise, supply and demand, gradually reducing GDP. The driving thing being cash flows for businesses and households. So it's really important that if we have an economic response to this that we're seeing, that it's really focusing on that cash flow side of things. Key lessons that we're getting from overseas are that government response has to be immediate and massive. The UK package is worth about 15% of GDP. Ours is currently 5%. But it's probably important not to design it all too early, because as this plays out in New Zealand, and we don't know how long this will play out for, we will need to respond in different ways. So it's probably a good idea to keep some back for later. But we also need to remember that health expenditure has to be a huge part of this, particularly targeted investments in system capability to protect our most vulnerable people. And I can stop there, but I'm happy to share the slides.
Yeah, thanks. Thanks, Sarah. That would be great. We don't have a lot of time for questions, so I have one that is from Lee Wilkinson, a very quick one. How much can we trust the data from China in terms of our modeling?
Yeah, that's a good question. I think we can probably trust the data from China as much as we can trust the data from anywhere. I don't think there's an issue that I would call a sort of a conspiracy theory that is relevant, but I think, you know, the data from everywhere has a lot of issues. We're not testing entire populations, so we don't have a very good denominator for our case fatality rates and for our percentages of serious disease. We also have issues at the moment around attributing deaths to COVID-19 as opposed to other causes, and it's not entirely clear how that data will look over time as those kinds of issues get cleaned up.
Okay, so thanks for that. Another quick question. So you did mention around the lockdown, and you know, New Zealand is locked down, and even though even after the lockdown, we probably won't be able to stream out from our homes to the woods. Now today, the cabinet, and I believe that the Parliament is having a meeting about whether we should extend our lockdown. Do you have a view on that?
I think it's probably too early at this stage to know whether we should be extending beyond 4 weeks. My view is that we should continue for the full 4 weeks. I know that there has been talk about ending it early. I think it's probably premature to do that. A week from now, we might know different. We've just been ramping up capability enormously, even over the last week, and we'll start to get a much clearer picture of the extent of community transmission, which is really key, I think, to making that decision.
Right. Sarah, thanks. Can you unshare your screen
yeah.
so that we are back to normal? Now, unfortunately, we run out of time. Sorry about that, you know, because that's our time range. So if you are happy to share your slides, that would be great.
Absolutely. Thank you.
So it's actually great to have you here. So we actually know that, you know, this COVID-19 is not as contagious as HIV, but it's slightly stronger than a seasonal flu. Now, we also get a bit of lessons from you around, you know, why we have actually done the lockdown a bit earlier, just, you know, in the Philadelphia versus St. Louis case, you know, that you have a picture that shows there. So there's quite a few things, and also thanks for telling us that, you know, we do have quite a few other things that we actually don't know about, which also bring us to maybe we should all buy David's Forsyth's big glass that looks like a pint so that we can keep drinking while we wait for some of these answers. Now, can we unleash our mic so that we can thank Sarah for having that session with us? Thank you very much, Sarah. Thanks. Over back to you, Didis.
Thank you so much, Sarah. It was absolutely worth staying with that very well prepared set of slides, because I think you're really giving us a great perspective, and I think it's important that we are hearing those kind of digests of the information coming at us, and you've caused us to think and probably see some of that information coming towards us in slightly different lights. So thank you again, and thank you, Sia, for moderating. So we're going to close, conscious that a number of people are still remarkably busy at this time and may have other meetings to get to shortly. I want to just draw your attention to a couple of things. The first up is we are active, so please look out for your Tuesday tweet, and in particular for the information in that about upcoming meetings and also projects that you can contribute to. And there will be further requests of that sort. On Thursday the 9th, that's this week, there will be a Zoom at 4 panel on managing finances in a crisis. And as Jordan mentioned earlier, we'll have a guest, Gillian Boys, who is a manager with the FMA, and then 3 of our own being CB Reeves, Andrew Austin, and Peter Lawson. And I think that will be a really valuable event, and Jordan, you're moderating that. And then on Monday the 13th, that is Easter Monday, we have an extra meeting since, after all, we are kind of all available. And we have our newest, or one of our newest club members, Sue Wells. Sue was a city councillor in Christchurch for 10 years, and she headed elements of the development and recovery committees for Christchurch City over that critical time from 2010 through to 2013. And she's going to speak to us about resilience and lessons from Christchurch. So please join us at 12:30 on Monday, next Monday. You're most welcome to bring guests. You're welcome to share the invitation to the meeting to your colleagues and family. And I'm sure we're going to find that a very good presentation too. Just in closing, we talked earlier about the quiet. This is a time for us to listen to people with interesting perspectives, to listen to our families, our loved ones, our friends. And I think it's a time, as Anthony pointed out, for Rotary to listen to the call from the community. I hope that we're going to be active in answering that call. Thank you all for your support today. Thank you for being here. Thank you again, Sarah, for your great presentation. And we'll see you, many of you, I hope, on Thursday for our Zoom at 4 session, and then again next Monday. Stay safe, stay well, and you know, we will kia kaha. Time for us to have courage and be bold. Okay, bye everybody. Thank you.
Oh, yeah, okay. Will do.